I would like to thank the organizers, Rivelto and his colleagues, for this invitation to visit your country. It's the third time I am in Brazil and always enjoying being here. I would like to show you first a slide. Can I have my slides, please? I come from Barcelona. This is, no, excuse me, this is my hospital. You cannot believe that. It is called the Hospital del Mar, which obviously in Spanish means the Hospital of the Sea, and it's really close to the sea. My office is 100 meters from the beach. It's not a very big hospital. We are not running a very, very high volume unit, but it's a modest hospital, but we are highly academic, and we've done some research that I feel it might interest you. In fact, Brazilians are very much interested in our unit. Have a look at this. Now, this is a map of the web visits that we get. We have a website for our endocrine surgery unit, and after Spain, the first country in the world that visits us is Brazil. That's amazing. And about 100 visits per year come from your country. And 20% to 30% come from Sao Paulo. And 10% come from Rio de Janeiro, and the remaining 60% from all over the country. The third country is the States, and the fourth is Russia. So thanks for visiting our website from time to time, and I hope maybe you're interested in the work we are doing. But I really wanted to share with you, you're very kind to come and visit us, unless not physically, but on our website. Now, we are going to talk about central neck dissection, which is quite a controversial issue, and I would like to start with this nice study from Ernesto Mazzaferri. Ernesto Mazzaferri was a great endocrinologist, especially before 2000. After 2000, he started to write very funny things about thyroglobulin, stimulated thyroglobulin, and radio ablation for everybody. I couldn't understand this, but in the initial stages, Ernesto was really a pioneer in figuring out papillary cancer. And this is one of his first publications, and I would like to draw your attention to the sites of cancer recurrence. Now, the site of recurrence already in the 60s and 70s was the thyroid and the centrals and the cervical lymph nodes, and this remains exactly the same, with one exception. We now are doing more and more total thyroidectomy, so there are no recurrences on the thyroid, and that's one of the major advantages of total thyroidectomy. So the next is the lymph nodes, and we are now talking about the lymph nodes, okay? So this is one of the rationale I bring you this slide, because I think we should now focus on cervical lymph nodes if we want to prevent recurrences. Which is the issue? Electron, I don't understand you keep on talking on survival, because survival in PTC is not electron around here? Oh, yes, you're right. I mean, you quoted Billy Moria. Billy Moria, of course, I mean, there's maybe not that difference between lobectomy and total thyroidectomy, but from recurrent side, it's relevant. We shouldn't talk about survival. I mean, survival is almost 100% for almost 100% of papillary cancers. So I think survival is going to be, in the next decade, will be something that we will not talk about. We will talk about recurrence. And if you talk about recurrence, there's something you cannot do. You cannot change the tumor size. You cannot change the extrathyroidal extension. But you can change a lot of things. You can change the extension of surgery, not only on the thyroid, but also on the lymph nodes. You should be looking carefully to the lateral cervical nodal involvement and to avoid incomplete initial surgery, which is the major cause of recurrence. Now, I like also very much this Billy Moria paper, and you see, Billy Moria already showed in a 40, 50,000 patients with papillary cancer, that those over 1 centimeter were benefiting from less recurrences if total thyroidectomy was done. I mean, you see here that also has some advantage for survival, but the numbers of patients here is very low, but the numbers of patients here is very high. I mean, between 5 and 20% of patients operated on for papillary cancer will recur, whereas only 2% will die. So despite this is significant, of course, here the numbers of patients benefited by total thyroidectomy is much less than the numbers of patients that can benefit from total thyroidectomy if you look at recurrence. Now, nodal status is very important for recurrence, whether you give or you don't give radioiodine. This is a Mayo Clinic report on N0 patients, either ablated or non-ablated, and you see that the recurrence rate for patients with N0, most of them treated with total or near total thyroidectomy, is just below 3 to 5, less than 5%. Now, recurrence for patients with N1, either in the central or in the lateral compartment, is much higher. You're gonna get about 15 to 20% recurrence at 15 years, whether you give iodine or whether you don't give iodine. In fact, in this Mayo Clinic series, patients treated with iodine had early recurrences that people that didn't get. The main message of this slide is that probably iodine does nothing to prevent recurrence for standard low-risk PTC, which amounts for 90% of our patients. Again, focusing on the relevance of the presence of nodes. Which nodes are mainly involved in recurrence? And the first are the central nodes. This is a nice study by Fra Soldati with total thyroidectomy without no dissection, and all patients got radioiodine ablation. And recurrence was 30, almost 10% in the central neck compartment, followed by recurrence on the lateral neck. So if you don't do any central neck dissection, probably the first step where you're going to get a recurrence is in compartment 6. Now, a bit of history. Compartment 6 seems to be something relatively new, but in fact, it was already described by the Japanese early in the 70s. And Electron was saying, that's a very relevant issue, that the Japanese authors were, for many years, treating patients with hemithyroidectomy and lymph node clearance from the paratracheal and lateral node. That was a standard therapy. In fact, in the early Clark's book, it was a nice chapter written by the Japanese on hemithyroidectomy plus lymph node dissection, because they were the first to figure out the relevance of the paratracheal nodes and the lateral nodes. So already in the 70s, in the other part of the world, they were already thinking about the relevance of central neck compartment. Not only in Japan, but also in the Scandinavian countries, there were two authors already in the late 80s and early 90s focusing on the relevance of the central compartment. In fact, the first description I found on the relevance of paratracheal clearance was written by Norwegian surgeons in 1988 reported quite a low rate of recurrence, just about 15% with patients treated from 1955 to 1980 something. And Tissell was also a very relevant author suggesting that the paratracheal nodes should be removed in patients with papillary cancer. In fact, both Tissell and Oye didn't use almost at all radioiodine ablation. They were just relying on thorough surgery for preventing recurrence. In fact, in Tissell's group, recurrence was around 9% without the use of radioiodine ablation. So most authors relying on surgery on the central compartment were rewarded by not getting too many recurrences despite not using radioiodine ablation. Now, you know what compartment 6 is, the central compartment going up from the hyoid to the venous brachiocephalic trunk. In fact, what is important for the surgeon is not just this drawing, but I like this one. So this is really the central compartment, which keeps on in continuity with the description by the Japanese authors and by the Scandinavian authors. So it's the paratracheal area, subiisthmus, and if that's the cancer, that's the parathyroid, covers the area going from the upper pole of the thyroid to the lower pole and just close to the clavicle. And this is what most of us used to clear when we talk about central neck dissection. We don't go up to the hyoid bone, we don't go back to the thymus and going to the mediastinum. We emphasize the role or the paratracheal nodes anterior and posterior to the recurrent laryngeal nerve. That's the real life in compartment number 6. You see here the upper parathyroid gland, the left, the right, that's on the right. For those of you who are not surgeons, you are looking to the right of the patient. You see here the left inferior thyroid artery, the thymus, the lower parathyroid, and then the recurrent laryngeal nerve with a nice metastasis just along the nerve and some metastasis behind the nerve. So especially in the right side, you should be very careful in looking behind the recurrent laryngeal nerve, where you can find, if you look for them, one of the advantages of doing central neck dissection is that you look for the nose, and then you suddenly, find a 1.5 centimeter metastatic lymph node behind the recurrent laryngeal nerve. If you don't care about the central neck compartment, you would probably miss this node, because sometimes it's hidden just behind the esophagus or in a paraesophageal situation. In the right, we should always look for the retrorecurrential space. On the left, things are easier. That was already pointed out by the Japanese, because most, if not all, the lymph nodes are in the front side, before anterior to the recurrent laryngeal nerve. So in the right, you probably have to do a more circumferential dissection of your nerve, but on the left, the dissection is usually more simple, because what you do is to reject all the lymph nodes in front of the recurrent laryngeal nerve. People usually talk about central neck dissection as if it was a single thing. And in fact, it's very different whether it's therapeutic, it's prophylactic, or it's associated with more extensive procedure. Some of the central neck dissections are done because the central nodes are obviously involved, and you do what we call a therapeutic central neck dissection. I don't think there's a controversy on that. If the surgeon finds suspicious nodes, obviously metastatic nodes, he should perform a central neck dissection, or maybe we should do that after total thyroidectomy done by another surgeon who means the central nodes. If we go for prophylactic, it may be ipsilateral or bilateral. We favor ipsilateral, but some people do bilateral. And we also have to put the central neck dissection in a context, whether the patient is, isolated gesture, or it's associated with modified radical neck dissection, or it's modified with extended thyroidectomy to the jugular vein of the muscles. So again, when we talk about central neck dissection, we should be very carefully looking at other circumstances, because then people say, well, central neck dissection has a very high rate of hypopara. Well, depends. If you do a total central neck dissection with this therapeutic, and you add a modified radical neck dissection in a papillary cancer that is invading the muscle, then obviously the hypopara rate will be higher than if you do a prophylactic dissection in patients with isolated total thyroidectomy and no extended dissection. So again, central neck dissection should be put in a certain context to know exactly where what are we talking about? This is obviously a therapeutic central neck dissection where you have a lot of lymph nodes involved. In these circumstances, you rarely can save the lower parathyroid gland, at least on the site of the tumor. You probably have also to remove the thymus, and you do a very traumatic dissection of your recurrent laryngeal nerve, but you have to do that. Otherwise, the patient will have a local recurrence. And persistence, already the Macy's score tell us that if you leave a tumor inside the patient after surgery, that's a major risk, not only for recurrence, but also for survival. The European Society of Endocrine Surgeons made a systematic review of the literature on the role and potential use of prophylactic central neck dissection, with the pros and cons of this surgical maneuver. And you see there's arguments really in favor, some arguments against that. I would probably, if you briefly conclude on this complex slide, you would then to say, be careful, because prophylactic neck dissection probably carries a higher morbidity if performed, if on the contrary, you perform an isolated total thyroidectomy. This, I think, it's kind of a summary of most of the contrast, because on the pros, you have a lot of things. You are not, probably you're getting more thyroglobulin negative patients. You are probably avoiding a lot of recurrences, of some of the recurrences. You will obviously increase the number of patients that won't get any iodine ablation. And, there are quite, from the oncological point of view, there are quite good reasons for doing that. But people are afraid of having more complications, and that's reasonable. That's something that we should understand. In this meta-analysis, what we saw is that temporary hypocalcemia is obviously increased if you perform a prophylactic central neck dissection, and this is something that has been reported in all the systematic reviews and meta-analysis on central neck dissection, on prophylactic central neck dissection. These studies have not found an impact on permanent. But we should be cautious about that, because to become significant, it means that you have to have a lot of difference, and there are not that many permanent hypoparathyroidism. But my rule is, if you have more temporaries, you probably will also have more permanents. So we all agree that if we add a prophylactic central neck dissection, we probably will have more, at least temporary hypocalcemias. So what's been our approach? Our approach has been to do that, but taking much care about the parathyroid glands. So I will go to some very brief key technical issues, which I think will help surgeons in the audience to understand how to do this with minimal morbidity. First of all, you have to provide quite a lengthy specimen. Now, this is a left prophylactic central neck dissection that was prophylactic up to 2 or 3 centimeters, but then you have a 1 centimeter metastatic papillary cancer node, about 4 centimeters from the thyroid. And this prophylactic central neck dissection became obviously a therapeutic one, just because we did it, just because we went for looking and doing the central neck dissection, that we were able to remove a lymph node that perhaps in a 36-year-old lady could be the cause of, or potential cause of recurrence, and even invasion of soft tissues around it. So if you don't look for the nodes, you probably will miss many of them. Now, preserve the thymus. That is essential. There's no reason whatsoever to remove the thymus and the connection with the lower parathyroid gland in prophylactic central neck dissection, because it means that you don't see any lymph nodes. So there's no reason to remove the thymus. And if we look carefully at the reasons for hypocalcemia, many of these hypocalcemias are reported in series where we don't know what the thymus was what the surgeon did with the thymus. Now, the thymus, for many surgeons, is just the fat around there. They are not used to individualize the thyrothymic ligament, and this is essential to understand the anatomy of the central neck. This is not the central compartment, or at least should not be removed, because if you remove the thymus, and probably this implies in many cases an accidental parathyroidectomy of the lower parathyroid gland, you're going to get in trouble. So in prophylactic central neck dissection, the thymus and the lower parathyroid gland should be preserved. And first, identify the parathyroid glands. You should not go for dissection without looking at the parathyroid glands. Otherwise, when you start removing the lymph nodes and the fatty tissue around the thyroid, you really don't know where the parathyroids are. So in this slide, for example, I'm showing you a beautiful upper parathyroid gland and the lower parathyroid gland before removing the fat and the nodes just anterior to the recurrent laryngeal nerve. And finally, if you do a prophylactic central neck dissection, do it on the same side of the tumor. It's very, very unusual to find metastasis in the contralateral lymph nodes in prophylactic central neck dissection. So we really insist on doing that just on one side. So if you do that on one side, if you look for the parathyroids, if you preserve the thymus, then your permanent hypoparathyroid rate should be lower, or should be at least the same as in isolated thyroidectomy. Now we would like to share our experience on central neck dissection with you. We did, a protocol about 20 years ago to do exactly the same to a series of patients with advanced PTC. I'm not talking about microcarcinoma. All the patients included in our series are patients with tumors above 1 centimeter. In fact, the median tumor size is 26 millimeters, which is rather high mean tumor size. The MACES was 5.3, and as Dr. Kebebi was saying, it's been shown to be useless from the point of view of recurrence. Again, we shouldn't talk about survival. MACES score was designed to predict survival, but now there's nothing to predict in survival, because survival is almost 98%. Extrathyroidal extension in 1/3 of the cases, and we have now a nice follow-up from 1 year to 18 years, and about 2/3 of the patients have been treated with radioiodine ablation. What's the numbers that we have in our series? About half of our patients required a therapeutic central neck dissection because the central neck was already involved with lymph nodes. And we were quite good at predicting that. About 94% of patients that we said that there was a therapeutic neck dissection, in fact, had metastatic nodes. On the other side, we have about 50%, about half of the series received a prophylactic CND. And look at this. If you do a therapeutic central neck dissection, about half of your patients will also have a modified radical neck dissection, because at the same time, we were able to diagnose lateral neck disease, whereas only 10% or even less, 8% of the patients with prophylactic central neck dissection had a modified radical neck dissection. So in the end, about 1/3 of our patients had a lateral dissection, and most of them had already an obviously metastatic compartment 6 involved. Let's see how the results were. When you look at recurrence, we will talk about recurrence more extensively tomorrow, but CND and recurrence are linked together. So most of our recurrences were found in patients with therapeutic central neck dissection that did not have a modified radical neck dissection and had a lateral recurrence. So that's by the book. That's what is happening in more than 50% of the recurrences. If you do a central neck dissection, you will have later on a recurrence on the lateral side. Even in patients with modified radical neck dissection, two of our patients, which is 5%, had a further lateral recurrence. So you see from the recurrence we have, if you have 12 patients with recurrence, 9 were found in patients with advanced central neck disease, metastatic disease. On the other side, if we look at the patients undergoing prophylactic central neck dissection, 5% had skip metastasis, which meant that at the same time we performed a modified radical neck dissection. So this was a clean central neck compartment, but associated to lateral neck involvement, which is quite commonly seen in patients with upper pole disease that metastasize to the lateral compartment but do not metastasize to the central neck compartment. In these patients, we haven't seen a single recurrence, and the recurrences we've seen with prophylactic central neck dissection on the lateral neck were those in whom prophylactic neck dissection was positive for metastatic nodes, which was about 1/3 of our patients. So from 27 of these 79 patients, 27 got metastasis in the central neck. So in this small series, about 3 of 27 patients with NO1 had a lateral recurrence. What is essential for us is that in the almost 8 years follow-up, and all these patients have been followed personally by me and my endocrinologist, so I'm not referring to what the endocrinologist says from a city 1,000 kilometers away from Barcelona. This is first-hand followed patients. We haven't had so far a single recurrence in the central neck. Now, if you look at complications, I always say it's not only due to central neck, because these patients also had total thyroidectomy and probably more extensive surgery. So if you compare therapeutic and prophylactic, of course, there are quite a lot of differences. First, although the T size is the same, and this is interesting because we still don't know exactly why tumors with the same size produce different metastatic disease. Extension, extrathyroidal extension was pretty much the same, but 50% of patients here required a lateral neck dissection, while only 9% required these from prophylactic. The resected nodes were double. Of course, in the therapeutic, you are more aggressive here. Many of these patients got bilateral dissection of compartment 6, because when you have macroscopic involvement, usually you can have metastasis at both sides of the neck. The presence of positive nodes was about 93% here, 40% here, and the number of metastatic nodes was obviously much more important in therapeutic. 5 out of 12 nodes were positive for metastatic disease, while only 1 of 6 was positive in the cases of prophylactic central neck dissection. So that's the picture, and now we are going to have a look at the complications of each of these 2 procedures. When you compare all recurrent laryngeal nerve complications, it was obviously that therapeutic neck dissections will carry a higher rate of recurrent laryngeal nerve problems, both temporary and permanent. We had 1 accidental injury and 6 oncological resections in this group of patients requiring recurrent laryngeal nerve resection because involved in the tumor, whereas on the other side, we have no iatrogenic injuries and we have 2 oncological resections. So, of course, this is different, and it's different because the therapeutic central neck dissection is a much more aggressive surgery than prophylactic. If you look at the prevalence of hypocalcemia, it was more prevalent in patients with therapeutic neck dissection, exactly the same for permanent hypoparathyroidism, which was 7.5 versus 2.5. This is one of the issues of the meta-analysis. It's very difficult that the meta-analysis that obviously show a difference between doing and not doing for temporary hypocalcemia, they have a lot of difficulty to find differences in hypoparathyroidism because the prevalence is much lower, and you will need probably much more number of patients. But in the end, I think it's relevant than if you do a more aggressive surgery, of course you are going to have more hypoparathyroidism. Accidental parathyroidectomy was seen in 1/3 of our patients and 1/5 in our patients with prophylactic. Recurrences were more common. Of 13 recurrences, 10 were seen in patients undergoing central neck dissection. But again, we didn't see any central neck recurrences in both groups. So to summarize, let's have a look at the risk of lateral recurrence according to N1A. This is the number of patients that didn't get any lateral dissection, that underwent central neck dissection, and that's the number of nodes that were involved. So if you do a central neck dissection and you have a 0 to 4 involved nodes, your chances of recurrence are very low. Lateral recurrence. Whereas if you have more than 4 involved nodes in the central neck, your chances of recurrence are much higher. So in addition to the possible advantages of avoiding central neck recurrences, staging for compartment 6 will also be useful for the prognosis of the patient, because the, let's say, the aggressiveness of follow-up would be a little bit more higher if you find a central neck dissection which colonized for more than 5. And all these patients, almost all these patients, at least in that side, receive radioiodine ablation. So radioiodine ablation doesn't mean that you don't have to follow the patients more closely. And I would like to finish by showing the relevance of T. We will talk tomorrow about the relevance of T for recurrence. The message to take home from this presentation is that T is essential. When you read a paper on PTC, look always at T size, because that's going to be what's going to mark the whole experience of that particular surgical group. If you read papers coming from Korea, for example, you'll find the mean T size is going to be 0.6 centimeters. If you go to the Mayo Clinic, you will see that it's about 17 millimeters, the mean size. If you go to Barcelona, it's 26. And this is closely related to the whole surgical, let's say, panorama. If you have a small tumors, you have less extrathyroidal extension, your mesis is lower, you will do less lateral dissections initially, you will have probably the same recurrence rate, and you probably will ablate less patients. So always have a look before going to the complication rate, before going to look at the recurrent laryngeal nerve paralysis or hypoparathyroidism, look at T, because the higher the T, probably the higher the aggressiveness of surgery and probably the higher number of complications, up to a certain stage. Of course, if you are not an experienced surgeon, you can do surgery with almost a normal thyroid and going up for recurrence rate of 10% and hypoparathyroidism of 15%. But T is essential to understand the biology of the tumor and how the surgeon should react to that. So in conclusion, I think that routine central neck dissection, in our experience, has eliminated central neck recurrences, which are very nasty for the surgeon. We don't like. We will talk about this tomorrow. Central neck dissection is associated to more extensive surgery, where it is therapeutic confronted with prophylactic, that's for sure. Iatrogenic permanent recurrent laryngeal nerve injury is uncommon after central neck dissection in our hands. Transient recurrent laryngeal paralysis is observed or was observed in 10% of patients with therapeutic central neck dissection. That's the double. Our rate with routine laryngoscopy after total thyroidectomy is 5% temporary nerve paralysis. So in this group of patients, you double your usual rate of temporary paralysis of the recurrent laryngeal nerve. Oncological resection of this nerve is necessary in up to 10% of patients with therapeutic central neck dissection. Also have a look at this, because that may also change the approach of the surgeon to the recurrent laryngeal nerve. And again, when you look at complications, also have to look at T size and the type of surgery was performed. Permanent complications of central neck dissection are almost restricted to therapeutic central neck dissection. And finally, central neck dissections, to our knowledge, represent a significant advance in PTC management, mostly regarding the avoidance of central neck recurrences. Thank you very much for your attention.